We'll continue on here with renal function part 2, starting with prostate cancer. So we talked about benign prostatic hypertrophy in the last section, and sometimes people develop prostate cancer. And there clearly are some genetic influences here. There are some genes that particularly regulate prostate growth. Also, though, we're familiar with BRCA1 and 2. We associate that with breast cancer in women, but mutations of those genes are also associated with prostate cancer in men. And about 5 to 10% of prostate cancer is actually an autosomal dominant inherited trait that occurs. Screening for prostate disease has been all over the map, just like screening recommendations for breast cancer have changed. Screening recommendations for prostate cancer have changed as well. One of the things that we do is look at the PSA, the prostate-specific antigen. We want it to be less than 4 nanograms per milliliter, but one study showed that 15% of people with a PSA less than 4 still had prostate cancer. So it's not 100% specific or sensitive test. Now, you have learned those terms or are learning those terms in, I think, in your parameters of health class, right? Specific and sensitive. So that just tells us how many false negatives and false positives you're going to get. So clearly, we have some false negatives here. So it looks like it's negative, but in fact, the patient really has the disease. Now, sometimes then we've done a digital rectal exam in men to actually palpate the prostate gland, because when you have a prostatic cancer, it feels different than it does if it's just benign prostatic hypertrophy. But there hasn't been any statistically significant association between routine screening and at least metastatic prostate cancer. So there's a lot of controversy about whether we should be doing that routinely in men or not. People that do have prostate cancer, the treatment recommendations are controversial. So we could do radiation, we could do radical prostatectomy, remove the prostate gland and the surrounding tissues, hormonal therapy, and the key determiner there is life expectancy. So if the life expectancy is short, that is, the man is already a certain age and the life expectancy for his age group is not much longer, then let's not treat the prostate cancer, because it's not going to prolong their life any. And if they do have if it's diagnosed at an earlier age, then we're probably going to be more aggressive with treatment. There's a saying that men die with prostate cancer, not of prostate cancer. That's not usually what kills them. It's something else that kills them, and men have prostate cancers for years and years. Some are fast-growing, though, and most are very slow-growing. So if you look at this website, it gives you some guidelines, and I just want to flip there for just a second to show what this looks like. So this website has all kinds of guidelines. Now, you do have to register on this site, but it's free. Let me scroll down to prostate. It may not let me look at it from here. Let's see, I probably have to log in or something, but so you can register for this and then look at any of these guidelines that you want to look at for cancer treatment. Okay. So moving on from prostate disorders, let's look at glomerular problems real quickly. So the glomerulus, again, is that beginning part of where filtration occurs and we get substances from the bloodstream into the kidney tubule. So there are glomerulopathies that directly affect the glomerulus. They can be hereditary. A lot of them are immune mediated. And we see some sediments appear in some of these disorders, and the composition of the sediment helps sort out what kind of disease process is happening. So there are nephrotic problems where the sediment that forms in the urine has a lot of protein in it. There are nephritic problems where you have some protein but also blood in the urine. And then there's a different kind of sediment that's associated with chronic glomerular disease. So by looking at the sediment that forms in the urine, that can help sort out what kind of disease process is happening in patients. So usually we see a sudden onset of high blood pressure, but it can be an insidious onset. It can happen over time. In association with that, swelling and increase in the BUN as waste products are not excreted. So BUN is blood urea nitrogen. That's a waste product from protein metabolism, and the kidneys are responsible for excreting that. So if the kidneys aren't working, that gets retained. We also see a reduction in glomerular filtration rate, and so we have increase in creatinine and urea, and a loss of surface area for the glomerulus to do the filtration work that it's supposed to do. One of the things that happens is we start to lose proteins into the urine, and so we end up with serum hypoalbuminemia, low albumin level in the bloodstream. And if you think about our fluid and electrolyte pressure picture, where we looked at hydrostatic pressure and oncotic pressure, we did that, right? So if you have low albumin, what would you expect? Yeah, decreased oncotic pressure, so we would see edema. So that's why these patients have edema. Glomerulonephritis is one of the conditions that we see, and this is associated with inflammation. And problems with the immune system are the most common cause. And one of the things that we see here, if we look at the bottom of the slide, streptococcal release of neuraminidase. This is acute post-streptococcal glomerulonephritis. This is to the kidneys as rheumatic heart disease or rheumatic fever, rheumatic heart disease is to the heart. So you have a strep infection, and because of the immune response that happens, you have damage to the kidneys. That's APSGN. Just like if you have damage to the heart after a streptococcal infection, it's the immune system that caused it, not the strep infection itself. Same thing here. Goodpasture syndrome is where we have antibodies formed against the basement membrane. This is an autoimmune disease, and we can have antigen-antibody complexes getting deposited in the renal structures. So nephrotic syndrome is a particular constellation of symptoms where we have excretion of large amounts of protein in the urine. Some kind of glomerular injury happens, and as a result we get low albumin levels and also low immunoglobulins. So albumin are the main protein that circulates in our bloodstream, but we talked earlier about the fact that immune substances, immune globulins, antibodies are proteins, clotting factors are proteins. So here we're looking at the immune globulins here. We also get elevation of lipids because the liver starts producing lipoproteins, and we end up with lipids in the urine. So this just shows a little picture of nephrotic syndrome. So we have some kind of damage to the glomerulus that increases the glomerular permeability, which allows proteins to pass across that glomerulus, which normally they don't do. We end up with proteins in the urine, so we lose our transport proteins. So what gets transported in the body bound to proteins? Oxygen is bound to hemoglobin. That typically isn't a protein that's significantly affected by this. But a lot of drugs are carried on proteins. A number of substances are carried on proteins. So if we're talking about drugs, if you have a low protein level, what happens to the drug level in your body? It goes up. You have more drug effect if you have a low protein level. You have more drug effect of a normally protein-bound drug. Okay? Thyroid is another one. Thyroid is bound to proteins. So if you don't have as many proteins, well, I'm having a little problem here because that says decreased thyroxine. I would expect that your thyroid effect is going to be increased because you have less thyroid connected to proteins. I'll have to go back and look at that and check that to see why we come down to decreased thyroxine. Then with the low albumin, we mentioned edema, and then that results in a production from the liver of lipoproteins, which causes us to have lipids in the urine, and then a decreased antibodies we mentioned as well. There's something you don't want to have happen. Yeah, I'm glad he wasn't sitting in the chair. Yeah. Okay, so let's talk a little bit about renal failure, and we'll touch briefly on both acute renal failure and chronic renal failure. So acute renal failure is classified into 3 different forms: pre-renal, intrarenal, and post-renal. And if nothing else, I want to make sure that you're clear that pre-renal failure is not a period of time before a patient goes into renal failure. That's not what we're talking about. It's not a period of time. It's a location, okay? So pre-renal has to do with problems getting blood flow to the kidneys. 60 to 70% of people with acute renal failure got there because they have pre-renal failure. Intrarenal is when there's damage to the kidneys themselves, to the structures in the kidneys, the nephrons. Now, certain subclasses of intrarenal failure are classified as acute tubular necrosis, and you often hear those two used. Actually, you often hear ATN and acute renal failure used interchangeably, but ATN is only one subset of acute renal failure, and it's specifically a portion of intrarenal failure. And then post-renal is you have an obstruction distal to the kidneys. Let me see what comes next here. So pre-renal failure, low blood flow to the kidneys. So hemorrhage could cause that. Any kind of hypovolemia could cause pre-renal failure. Heart failure, if you don't have enough cardiac output, any of those things could cause pre-renal failure. Intrarenal failure, usually associated with nephrotoxins, dyes for dye study, medications that we give, NSAIDs, damaging to the kidneys, aminoglycoside antibiotics, damaging to the kidneys. But if pre-renal failure goes on long enough, the kidneys aren't getting enough blood, it's going to cause intrarenal damage as well. So prolonged pre-renal failure can lead to intrarenal failure. And then post-renal is after the kidneys. Now, the little arrow is pointing to the ureter, but if you have blockage of one ureter, you're not going to get renal failure. But if for some reason you had blockage of both if you had blockage of both ureters, you could have renal failure. But more likely what we might see is blockage of the urethra and backup of urine. And occasionally you see that in people with prostate disease, where they have so significant obstruction of their urine outflow for such a long period of time, they have so much urine backing up that they actually have renal failure because of prostate disease. So just a little diagram to show what's happening here. So this is showing either ischemia, lack of blood supply to the kidneys, or nephrotoxins. Either one of those is going to release those inflammatory mediators that we talked about week 2. Vascular endothelial cell injury, vasoconstriction. We're going to have a reduction of glomerular filtration pressure, which is going to reduce our GFR, leading to low urine output. Going to continue to have hypoxia to the renal tissue. That's going to damage the tubules themselves. We get necrosis and apoptosis, formation of casts that block the renal flow even further, back leak of fluids in the tubules, and ultimately, again, low urine output and low renal function. This is just another picture showing here's the urine flow. We get increased pressure in the renal tubule here. The back leak is leakage of the renal tubule contents out into the tissue instead of so this is potentially urine if it goes far enough through the tubule, but here it's leaking out into the interstitial space. So when people have acute renal failure, they go through often 3 phases: an initiation phase, a maintenance phase, and a recovery phase. And the key thing about this is that even when the BUN and creatinine return to normal levels, that doesn't mean that the kidneys are completely repaired. And it can take 6 months to a year for the kidneys to completely resolve from an episode of acute renal failure. And if the acute renal failure damage is severe enough, or if it goes on long enough, they can develop chronic renal failure. So chronic renal failure is an irreversible loss of renal function. So we didn't say that, but acute renal failure is at least theoretically reversible. It's some cause like hypoperfusion, where if we give them enough fluid or enough blood products, we could get their perfusion back again. Potentially, we could correct that acute renal failure. But chronic renal failure is not even theoretically reversible. Once that's started, it's going to continue. And although we're talking about the kidneys, all the body systems are affected because the functions of the kidney affect the whole body. So we go through some stages here too, where we see initially diminished renal reserve. Usually we don't know that the patient has this because their BUN and creatinine are normal, and there's no reason to do further studies unless we just randomly do them and find out that they have problems. And what we'll see is that their creatinine clearance is decreased. And that's creatinine, just like BUN, is a waste product that's normally excreted by the kidneys. But if it's not getting excreted, then that's an indicator that the renal function is not normal. So to do a creatinine clearance, usually do a blood creatinine level and a 24-hour urine test and compare to see how much creatinine is being excreted. Then we move into a phase of renal insufficiency, and you often see that abbreviated on charts as CRI, chronic renal insufficiency, where the BUN and creatinine begin to be elevated, and then in end-stage renal disease, they need dialysis or transplant in order to continue to stay alive. So here's a staging of renal failure looking at the glomerular filtration rate. And so we calculate what that is, and as it gets lower and lower, we move through these stages until they need a transplant or dialysis. So lots of things can cause chronic renal failure, including ongoing acute renal failure. But these top three are in order. So diabetes is the #1 cause of chronic renal failure. About a third of patients on dialysis are there because of diabetes. High blood pressure and glomerulonephritis, that's the #3 cause, and then the other ones. Autoimmune diseases like good pastures that we mentioned, or polycystic kidney disease are causes of chronic renal failure. So we have atrophy of those renal tubules, we have hardening of the glomerulus itself, fibrosis of the tissue, and then we have inflammatory changes happen so that white blood cells come to the area, and all of that makes the nephrons not work. So when the nephrons don't work, we have these effects that we recognize as the signs and symptoms of chronic renal failure. So we have a low erythropoietin because it's not just the fluid and electrolyte functions that are affected, it's all the functions of the kidneys. So they're not producing erythropoietin, so they become anemic. Because of the low glomerular filtration rate, they're not excreting hydrogen ion. We just talked about that with acid base. So they end up with metabolic acidosis. They also don't excrete potassium. They also don't excrete sodium and water. They also don't excrete nitrogen wastes like creatinine and BUN. And when you have an elevated creatinine and BUN, that's called azotemia. So you see that sometimes on charts. And then they also don't excrete phosphorus. So all of those substances are elevated in the bloodstream. Hydrogen ion, potassium, sodium and water, BUN and creatinine, and phosphorus. Also, they have difficulty excreting magnesium, and that's not on this chart, but that's one of the electrolytes that's not excreted very well either. Now, the kidneys are part of the metabolism of vitamin D. And so when the kidneys aren't working, we aren't finishing our production of vitamin D, so we get low serum calcium as well, and that leads to bone breakdown. So we can't excrete fluids, so we have fluid backup and evidence of that with edema, fluid in the lungs, crackles. Many patients with chronic renal failure have no urine output. Because we're not able to excrete hydrogen ions, we get metabolic acidosis and all the signs and symptoms that we just talked about a minute ago. Now the hyperkalemia, let's talk about that for a minute. So we know already in metabolic acidosis that patients can't excrete, in renal failure that patients can't excrete potassium. But what also happens is in the bloodstream, if we have lots of hydrogen ions circulating in the bloodstream, in an attempt to counterbalance that, to reduce the acid load, hydrogen ions will move into the cells, but in exchange, something has to come out. So what comes out? Potassium ions. So as the hydrogen ions move into the cells, potassium ions move out. So you end up with hyperkalemia. In addition, we just can't excrete potassium ions, so we have problems with dysrhythmias and the other signs and symptoms of hyperkalemia that we just talked about. We also can't excrete magnesium, which also affects muscle function and also cardiac rhythm. And then those waste products aren't excreted. And we don't know for sure what the mechanism of this is, but it appears that those elevations in creatinine and BUN are what cause the itchy skin that people with renal failure have, some of the nausea that people with renal failure have, and some of the peripheral neuropathies. That the accumulation of those waste products are actually damaging the nerves that lead to the neuropathies in renal failure. Do you know what a negative inotropic effect is? Decreased contractility of the heart. And then the vitamin D production, we talked about this, so we're not able to excrete phosphorus and we're not able to absorb calcium, so the phosphorus level is high and the calcium level is low. And the erythropoietin, we're not producing red blood cells in the bone marrow. And notice that it's a normocytic, normochromic anemia. There's nothing wrong with the red blood cells that are being formed, there are just not enough of them. Patients with renal failure are on lots of medications, but they're also on lots of dietary restrictions because of their kidneys' ability or inability to manage all of these things. So we restrict all of these things in the diet, which leaves them not much to eat. It's not a very fun life to lead. Now for medications, we often give medications that bind that phosphorus so that it gets excreted through the GI tract. And Phoslo is one of the things that we used to use a lot. It's an antacid, so it looks like, well, gosh, it's just an antacid. Why do I have to worry about giving this? But we're not giving it for the antacid effect. We're giving it to bind the phosphorus. So it's really important. It's not something that you want to skip if you're in a hurry and say, oh, gosh, I don't have time. It's just an antacid. I'll skip it. That's not why they're getting it. So it's very important that they get that. But more and more we see patients taking Renagel, which is another medication that binds phosphorus to get it excreted through the GI tract. And then we supplement their calcium often with Tums. Again, not something that you want to skip. They need that because of their calcium imbalance. And then also supplementing their vitamin D as well. And then often there's some kind of erythropoietin supplement to get their anemia under control. ACE inhibitors are being used more and more whether patients have heart failure or high blood pressure or not, because the ACE inhibitors protect the kidneys, and so it helps prevent progression of their renal failure if we give them ACE inhibitors. And then we certainly want to avoid drugs that have magnesium since they're not able to excrete it. And most of the antacids that are on the market are a combination of magnesium, and aluminum. So like Mylanta and Maalox, they contain magnesium, even though that's not in their name anywhere. So we want to be sure and educate patients to avoid those. And certainly they need to avoid milk of magnesia, mag citrate, those things. They don't need more magnesium added to their body. Then they're often needing treatment for high blood pressure, diabetes, depending on what else is going on with their body. So you know this, chronic renal failure patients are on pages and pages and pages of medications. And if you ever have any questions about whether you should give something before dialysis or not, ask the dialysis nurse. They can help you figure it out, or the pharmacy. Any drug that's cleared by the kidneys, you don't want to give before dialysis because it's just going to be cleared out by the dialysis treatment. Okay, so we'll talk about this slide when we look at the case study. And this is Fort Casey up on Whidbey Island. So I'll leave you with that picture and we'll move to our case study.